to conduct antibody tests in the country. And Wellcome Trust, being one of the premier research institutions in Kenya and collaborating with KEMRI, they have gone ahead of time and been able actually to provide with some preliminary findings among blood donors. So the work they're doing actually is really commendable.
Okay, and from the report, they did look at 2,535 blood samples
Yes.
from people who had donated blood, which is basically an antibody test. So for the people have been seeing the COVID-19 tests being the PCR. So what was the modality behind this? Why would you take blood to look for the antibodies?
I think first of all, back to the media frenzy that I've been seeing today on social media and whatever platforms talking about the millions of people being infected. I think first of all, we need to correct that position, that that's not accurate. I mean, the way you interpret those kind of results, you do not extrapolate and say 3 million or 2.5 million Kenyans are infected. There's a need to understand that the kind of study that they're involved in is based on high-risk populations where people are voluntarily donating blood. And in these cases, you'll find that the sample that they're using in this study is extremely small and it's unadjusted. So when you're doing sampling for any studies that you have to adjust to cater for other confounding things that arise. So we tend to overgeneralize the true picture of the disease based on misinterpretation. And this happens all the time. I mean, whether you're a medical researcher or whatever. So that's the first thing, that it's not true that 2.6 million Kenyans are being exposed to coronavirus. I think that has to be very, very fundamentally corrected. In terms of why blood, is because there are two different types of tests that you want to talk about here. There is a diagnostic test, which is purely a PCR, which is a polymerase chain reaction. And in PCR, what happens is that we are trying to amplify the DNA or the RNA of a virus. In this case, for coronavirus, you are actually trying to amplify the RNA part of the virus. So PCR, which is being used for basic diagnostics, is basically a detection of the genetic material of the virus. And this is possible when someone is actually infected. The samples for PCR are strictly from the nose, the painful thing that they put that long swab into the nose, taking the nasopharyngeal swabs. That's how we call them. Now, when it comes to the blood tests, which is now the antibody test, which we call the serological test, the antibody test tells you the proportion of the people who have been exposed. They might not be really infected actively because antibodies are generated a week or two after the actual infection, and after some time they might clear from the system. So it tells you who's been infected, but also it can provide an indication of who could be immune to the disease. So antibody tests are very key in determining the population as it's developing an immunity profile. The main difference is that when you're looking at PCR, you're looking at it helps you to determine the people who have been actually infected, and therefore you can implement issues of isolation of those people so that they don't get in contact with other people. And this is the importance of going in and doing the PCR test. It's truly advantageous because now they're optimizing the PCR test so that the return from testing, it gets shorter. And the main purpose is, if you know these people, you can interrupt the transmission chain. So you know the dynamic of transmission of the disease. So that's the main difference. So in PCR, you do not use blood at all. But in serology, where you're detecting the antibodies, you are actually using blood samples.
All right. And you've explained that very well, and brings me to my next question. When in epidemiology, you have the incidence and you have the prevalence. So basically, this study from this KEMRI-Wellcome Trust was not indicative of the incidence. That's like the number of cases we are having, and it was showing the prevalence. Yes? And you've stated like that 2.6 billion figure is quite high. So because it was a bit alarmist for Kenyans who read the dailies today morning. But just based on that study, what can you tell us about our prevalence in the country? Like, you know, it's been almost 4 months now.
I think when you're talking about prevalence, and this should be, maybe we need to define these two terms and just make it very clear that when you're talking about the incidence, these are the number of new cases during a specified time interval, meaning you have a proportion or a rate of people. Sometimes we call it attack rate, sometimes people call it a risk, and the denominator here is basically, let's say in Kenya, by yesterday or whatever, they had tested about maybe 175,000 people or something. And out of this, you find that probably 7,000 or whatever are positive. So the incidence here are actually those actual cases, the new cases, that small percentage of about probably 3.5 or 3.8%. But when you're looking about prevalence here gives you, it differs from incidence in case that you have all cases. This is including the new cases, okay, and then the pre-existing cases. So in the population that is specified, where incidence, we are strictly talking about only new cases. So that is the difference, that you find that you can go back even to January of 2020 and calculate the prevalence, but you cannot go back to January 2020 to calculate the incidence. The incidence is that the new cases are there emerging. So what the Wellcome Trust did actually, they tried to estimate the prevalence based on voluntary blood donors who had, of course, informed consent to participate in this and try to help them actually understand whatever is happening. And when you look at the brief, Nairobi comes up to about over 12%, while maybe other areas have much lower, maybe Uasin Gishu or something of that kind. And you find that this is very skewed, kind of, even if you read the report clearly, they're really requesting people to interpret this with caution, given the extremely small sample sizes, and also a caution in terms of the sampling strategy of the approach. This is convenient sampling. So it's not kind of a randomized, kind of approach. When you want to do a vaccine study where you want to go for a randomized control trial, this is very convenient and is based on actually on the availability of people. There's a potential actually to induce bias in the analysis because probably you're dealing with only people who are suspected to be suffering from the disease and they might be high-risk population. But if you wanted to conduct a true prevalence study, you're going to go in sort of a blind effort whereby you are approaching an entire population and you want to understand, for example, you want to go all the way to Busia or Kilifi or wherever and randomly go into populations and try to sample these populations and run the antibody test and be able actually to say, are we seeing antibodies? Now, there are two types of antibodies, what we need to understand. There is an antibody which shows earlier on in the infection, which is called the immunoglobulin M, which is the IgG-M. When you have that graph, the graph will show you that the IgM, which is the immunoglobulin M, appears earlier. But then we have the IgG, which is the immunoglobulin G. This means that you might be having this infection for a longer period. Now, what the study didn't tell us, the Wellcome Trust study, it didn't go into the depth. Maybe it's in another document, but the brief didn't go into depth to explain to us whether the antibodies that they observed were IgM or whether these antibodies were IgG. Given IgG will be later exposure due to prolonged and frequent exposure to the pathogen, while IgM will be immediate, probably let's say in 1 week, whereby you started now to detect actually the antibody circulating. So the brief, the policy brief, which actually I've read and is very good, did not actually go into that.
Okay. And right now, we also posed this question to the CAS for the Ministry of Health, because we asked him, like, what does this say about our epidemiological curve? You know, they've mentioned that the peak will be in September, should brace for a peak in September, but since this virus, the virus cases were being recorded in Kenya and up to where we are now, how is our epidemiological curve looking like?
I think when you look at comparatively the global epidemiological evolution of COVID-19 being a new disease for the last 6 months, we have witnessed this in the countries that have been struck very hard, and this also can be observed, whereby at the beginning we are having the doubling rate. So when you want to see that the disease is growing, you are seeing that after every so often number of days, let's say maybe a number of days of 10, it's doubling very fast. We started with maybe 300 in the month of March, and then we are seeing these numbers increasing to thousands, and now we are having 4,000 plus in the month of June. So that tells you that this is a rapidly evolving epidemic that is growing in as much as the community transmission is being sustained, whereby the human-to-human transmission is increasing on a daily basis due to an increased contact rate between the people. We haven't yet reached the peak, but the way we are seeing with the doubling rates, I mean, in the number of people that are being infected, let's say you are infected, and how many people can you infect, what we call the R0. So our R0 is not going down. Actually, our R0 is being sustained and is going higher. For example, if I say the R0 is 2, it means that if I'm infected with the disease, I have potential actually to infect 2 more people, and then you escalate it in that fashion, it goes on. So we need to prepare actually for a very unprecedented period in the coming month, given that it's also coinciding with the flu season or whatever globally, that we might actually see the cases rising exponentially if the mitigation strategies are not put in place to actually suppress the spread of the virus. So I think the ministry is also doing very well in terms of providing the daily, briefs, which actually can tell us the picture of where it's going. But I think when we were discussing about the antibody test, I think I clarified that. So maybe, we can go to the next question.
All right. And then from that, how you've explained the curve and how we have not yet at the peak, but we are almost getting there. And what advice can you give to Kenyans, particularly those who are thinking, 2.6 million of us have this. It's in a population of 47 million. There are Kenyans who believe that even with the small numbers, it's still not as high. What is your advice to Kenyans?
I think first of all, I need to dissociate myself with that number 2.6 very strongly. That I wouldn't want to be quoted. I don't want to be quoted that I'm talking about the number at all as a scientist. I want to maybe emphasize on one of the things that it doesn't mean that if you've been exposed to the virus and survived without knowing it. I think that's the main concern. People are, writing these things and saying, I think I got sick earlier on and I survived this. So it means that I'm immune to this. Some people are saying, in February, my mother, my wife, whatever, got very sick and they recovered. So this is the thing. We need to understand that you cannot just develop immunity by being exposed to the virus. As we said earlier on, when you're doing the antibody test, you want to detect if the antibodies are mounting a response to fight the invading virus. Now, not all antibodies are protective against the virus. You have some antibodies which are just expressed, but then you need to have neutralizing antibodies. What we don't know about the neutralizing antibodies, and from some studies which have recently been published in Nature, is how long does this immunity actually last in the human population? Nobody knows that. Some people say 3 months and it went away. So in terms of, even if you have very low levels of the powerful neutralizing antibodies, what they do is that they provide a sterilizing effect. So the antibodies actually are able to know and recognize that there's a new pathogen or there's a new virus which is coming into the body, and then they go to attack mode. So by attack mode, they crush actually that enemy that is coming in terms of a virus. But we talk a lot about antibodies, but when you go deeper, people also need to understand that it's not just the antibodies. The body also has some other defense mechanisms, which we call the T cells. These are killer cells, actually, literally. It's because they target the cells that are already infected, and then they go probably and destroy those cells to avoid spreading to other organisms. So when they're doing the antibody tests, there's also a further investigation to go and understand the immunological profile of the people, where the T cells, which are called the T killer cells, need to be detectable. And this is very key because you can have the antibodies, but then you do not have the right T cells, or also you do not have the right B cells. These are memory cells. B cells, they remember, and this is the basis of vaccination. They remember that actually there was an infection of this kind, and actually they are able actually to mount an attack to the cells. So what Kenyans need to look out for is that the anxiety that is building in the population due to extended lockdowns might be justified in terms of the economic standpoint or socio-economic issues. But then the biggest question is you need to weigh between wealth and health. Do you need to go out there, open bars, open restaurants, like what we're observing in other countries where you're having an upsurge in the United States, that they're opening up and everything is spiking up? So while it's justifiable to discuss, the elements of when to reopen and want to reopen, you can only open this. And I have said this many times. When you have evidence that there is a substantial reduction, there's evidence that the number of cases are decreasing. The WHO and African CDC uses the same template whereby you need to have about 14 days of actually having either no positive case being reported at all or probably having very low numbers for you to confidently make a decision based on the evidence that we are winning the war against the virus. So as it is right now, I think we are not winning the war. I think today we had 240 something, and these numbers may be expected to rise even into maybe 500 cases per day. The more you test, the more you're going to get the virus occurring.
Mm-hmm. All right, and that's very crucial. Then also, just to, if this is within your domain, like yesterday they mentioned the NCDs, people who have non-communicable diseases being more vulnerable, and diabetes kept coming up. And we've seen out of the 149 deaths yesterday, majority had diabetes. So why are people with diabetes more vulnerable to this COVID-19, especially for deaths?
Yeah, that's a good question. Like all diseases, you need your body to be in good shape to fight them. Now, if you have any underlying infection, whether it's diabetes, whether it's hypertension, or whether you have obesity, and then this means that you are slightly immunocompromised. For example, let's say you have HIV/AIDS. It means that those cells I was talking about, those T killer cells, those B cells, your immunity is not actually configured well to fight some of these infections. So the rapid kind of what we call the cytokine response, when the virus is introduced into the body at this moment, let's say the coronavirus comes, there is a kind of a drastic change whereby the defense of the body wants to rush in to go and neutralize the infection, but the body does not have that ability to do that. So it means that you are more vulnerable because your body is very weak, and actually the virus can actually propagate and sustain its multiplication into your body. So that's why those people who are having those underlying conditions that are higher risk of actually, developing from a mild infection to more severe infection. So basically, that's why you need to actually keep those people away. You need to keep older people away, and you need actually to shield and segment those people who are having all these underlying conditions.
Mm-hmm. So there was this receptor for people in diabetes. I don't know if it's the AC2. What is the correlation with COVID-19 for diabetics?
The ACE2 is a receptor.
Yes.
So this receptor, let's say it's a Y-shaped receptor, it's what the virus has propensity to attach to. So every virus evolves and has the ability actually to attach and actually to migrate, specifically to multiply better. So you find that their kind of patients, probably the specific demographic that you mentioned, they might be able, actually, let's say like male people might express probably the acetylcholine 2 enzyme, and therefore the virus finds it easier actually to attach. So the more a success in terms of producing the ACE receptors, and then also the more successful actually the virus becomes in terms of attaching and actually multiplying into the body.
Okay, and then my final question, and it's because you've given your parting shot. Sorry to take you back about the herd immunity. what exactly is herd immunity, and how can this be achieved with COVID-19?
Yeah. Sweden. Sweden is very popular, and everybody was praising Sweden and saying, they've done amazing work. They have herd immunity, and all this was a fallacy. So this is how herd immunity works. So herd immunity means that you need to have a threshold, what we called, a herd of animals. So we have a herd of cattle, goats, or whatever. That is the basis of herd immunity. So it means that we have 10 animals, and 6 of those animals get infected in a herd. So it means that those 6, when they get exposed, there's a way that the immunity will build so that they can fight the disease better, and then they will be able to protect the rest of the 4 in that herd. So that's how essentially the definition of herd immunity, it's a borrowed word from animal modeling studies from veterinary epidemiology. So by herd immunity in the human population, for example, with the coronavirus, this is what it means. It means that you need to have a high level of number of people in our population. An example, we have 48 million Kenyans, maybe. So we are talking about having 60% of the 48 million Kenyans, which will translate to about maybe 28 million Kenyans, being exposed to coronavirus and being able to generate neutralizing antibodies so that they can protect the rest of the 20 million who are not exposed to this disease. And this is what the concept of herd immunity comes in. So they're protecting the rest of the herds. And this is unattainable. I mean, when you look at it the way it is, it's unattainable totally all over the world. There's no country. So when you do the prevalence studies, the way the Wellcome Trust is doing, they need to find 60% of Kenyans actually from the sampling having been previously exposed to the virus. So while herd immunity is good, it's only feasible when you're looking at a vaccination strategy, whereby you want to develop a coronavirus vaccine and be able actually to cover about 60% of the human population, whether globally or at a country level. And this will actually be able to confer immunity to this population so that these people won't be able to spread their disease to the other group of people that has not been exposed to the infection. So I think it's a word that is being loosely used. But when you look at it, all in all, being a very new virus, is only 6 months old. There's a lot which is unknown. There are about thousands of vaccine candidates right now. And the basis of this is that they are trying actually to identify the best neutralizing antibodies that they can use actually experimentally. For example, the same Wellcome Trust and other organizations in Kenya, they're trying to test sort of an adenovirus vaccine, whereby they want to see actually if this vaccine can be able to mount this. So unless you have the vaccine, which we don't have, and we don't know when it's going to happen this. I mean, in the US, people are talking about 18 months, but this might take longer. We shouldn't actually be talking about or even thinking about the phenomenon called herd immunity, because it will all mean that we are intentionally trying to expose ourselves to disease so that the more we get sick and the more we think we are going to heal. And this is the approach that the UK government initially used. The UK government made all these arguments, and then they realized that actually what they were making was a very, very big mistake. And they abandoned it quickly, and then they came back actually to treat, test, and isolate populations. And that's the only strategy that can actually help you to check actually the rapid spread of this disease. Thank you very much.
All right, and thank you so much, Daktari. Do you have any other final parting shot, or you're good to go?
I think we should actually support efforts of medical researchers like what the Wellcome Trust is doing. There's a need actually for the public to trust public health officials and medical researchers. I mean, the kind of unwarranted criticism and attacks to people who are trying to provide evidence, I think it shouldn't be really checked. And this is not just happening in Kenya alone, it's happening everywhere. People are attacking scientists and medical researchers like us and saying, you're misleading us because you're making people actually to suffer a lot. So the trust, you cannot win a pandemic when you do not have public trust into the systems. You cannot win a pandemic when the communication strategies for risk communication or behavioral change is fragmented. So there's a need actually for the government also to tailor communication strategies that actually sound well to the public and they're easily to consume and the people should understand. For example, that policy brief is a very, very important document So it needs to be broken down to the Mwananchi so that they actually understand what really the study means. If it's too technical, and then you find people start becoming very aggressive because, again, many people are ignorant. And sometimes if you're ignorant, you can make your own decisions. So public trust and support for biomedical research, and the media have a responsible way of reporting. I think the media needs actually to be checking on with the experts so that we do not want to make headlines because we want to sell some information. I think there has to be a trust between the media and also the medical researchers. The media is the eyes of us, the medical researchers. So when I say something and it's misinterpreted, and then my head can be put on the chopping board. So thank you very much.
All right, thank you very much, Dr. Thank you for joining us.
Thank you too, and thank you.
All right, thank you. So I'll let you know when we have, because we have one story for tonight, then the others would be in our subsequent bulletins. Thank you.
Okay. So what time?
At 9 p.m., I'll see if I can make it for 7 as well. But 9 p.m. for today. Yeah.
Today,
thank you. Yeah.
Thank you very much. And I'm always available to talk to people. I always want people not to misquote me. That's why I believe in video recordings, because with video recordings, I can have my own evidence against any media station. Okay. And I'll be very happy to continue sharing any information as it emerges. Thank you very much, Dorcas.
All right, thank you.
Okay.
Marcy, I'm coming for the card. Eh? Yeah. Ooh.